Right, this is pearls of wisdom. We're going to try something. This is quite hard. I've always found that if we can get over a message quickly, this is very good practice for those of you that have to go to a board meeting. You have to get over this message very quickly. So what this is about is about getting a message over to you, and you think, I need to speak to that person. I need to find out more. And this session's about that. So everybody's got about 8 minutes, all right? I'm going to be quite ruthless, because that's what I'm like, on the timing. But what this is about is these people have worked really hard to try and get a message through to you in about 8 minutes. So it's pearls of wisdom, innovations, thought processes, but going to try and get, and they've been very brave to do this. I'm not sure I would. So without further ado, I'm going to ask Ruth to come up and do the first 8 minutes. So Ruth, you've got
no
8
pressure.
minutes and no conferring.
Okay, my talk today is going to be about cancer pathways and the importance of the data following the patient. I thought I'd start with a bit of a mock the week moment where I've got various statistics up there, and you kind of got to guess what those statistics mean. So, 1 in 2 adults will be diagnosed with cancer. 1,000 people a day are diagnosed with cancer. By 2030, 4 million people will be living with cancer. 50% of people will be surviving for at least 10 years in a couple of years' time. So what we are seeing is the survival rates for patients diagnosed with cancer is vastly improving, and the Cancer Task Force strategy is very much around focusing on quality of life. So I'm just setting a bit of context around the cancer agenda at the moment, because I appreciate we've got a mixed audience. On the right-hand side, you can see cancer referrals are increasing. So all of our healthcare professions have got an increasing workload that is happening, and we need to look to technology to help manage that increased workload. And of course, we know these figures because this has been captured through structured data. It forms part of the patient record and is routinely processed and collected as part of consulting with the patient. This data is also used to benchmark the UK's performance with other countries, because we need to understand whether we are doing well or not well to bring about improvements. So that's the context, but how does this all happen? Because I'm sure a lot of people don't actually know what goes on behind the scene. So the diagram here is around the mechanism that takes place with a number of data sets. So we start with the Cancer Outcomes Services data set called COSD. A lot of information is processed from your multidisciplinary team meetings, and then we have a series of clinical data sets, and your local trusts will be processing this on a monthly basis. The data is submitted, and OnCall, on the right-hand side, is the national system that processes all of this information. It's a massive operation. The data that is stored in OnCall is used to help inform policy decisions, identify variation in practices. It's used for commissioning services, and it is also available to the public via various charitable sites like Macmillan or Cancer Research. And also more recently, a clinical dashboard has been published, and again, this is available to healthcare professionals and the public. This is just another slide in terms of how the data is merged, because data for the same patient does come from many different organisations. The data also that is processed covers national audit data sets. So there is a vast range of data within OnCall. And the data we capture today is actually used to make tomorrow's decisions, so it's important we get it right. So where do we fit in? So we're Somerset Cancer Register. we are employed by the NHS and we have developed a product, so we are one system supplier that helps support this process. The Venn diagram shows you where all the overlaps take place, because in terms of meeting the reporting requirements, we do need a certain amount of clinical information, whether that's meeting cancer wait times or meeting some of the COSD requirements. So that's why our system exists. We're very proud of the fact that our system is actually nearly 100 trusts, so that's no mean feat for an NHS IT provider. The problem we had is that there was a lot of duplication from our system. So where we had those overlaps, then that did mean predominantly admin staff were taking information from one system to another. So with the increasing workload, we know that we had to move forward and do something about that. And this is where interoperability comes in. So interoperability is key, and it's key for the data to follow the patient. So you'll see on the diagram, although it's quite a busy diagram, it does show that if you move from a SCR system, and it doesn't have to be SCR, it can be another cancer system, the e-tertiary little circle means that the patient referral information can go from one trust to another trust. And if you think about cancer referral pathways, then that is typical of what happens to a patient throughout their journey. The e-tertiary referral was developed with NHS Digital using secure technology, meeting the industrial standards, and making sure that we consulted with our users in terms of what was key in terms of information that needed to be shared between organisations. So the data does need to follow the patient. The other thing that we have introduced to reduce the duplication, as per the previous Venn diagram, at the bottom of the screen you see EPR, pathology, radiology, oncology, endoscopy. That information this year will be coming automatically into our system, so that has cut down on the duplication. So we are doing away with the duplication. We are now starting to get the patient data to follow the patient where they go. The dotted lines represent the areas that we have yet to develop. So we are now starting to hit unknown territory in terms of data sets that need to be shared. So we have a couple of established clinical portals out there. The clinical portals are about bringing together health and social care. Some are used for patients, some are used for remote monitoring, and it's about enabling that data to be shared with clinicians, whether you're a GP, you're the acute trust, or you're a mental health trust. But what we are finding is that there are no defined data sets out there. And if we are to keep the technology affordable for trusts, we do need to come up with some common data sets that can be used by all. I think that's one of the tricks that we need to be harnessing. Now, what's not shown on here is primary care. The other area we're looking at, we've worked with Macmillan, is around looking at what information is it that GPs need to have, but we don't want to pass a PDF over to the GP. Again, we want a structured message to go to the GP practice so that the data sits in their system. It means that a human doesn't need to intervene to put that information in. We want it to go directly into the system. That way, we'll then start to see patient really starting to flow. What are the barriers? There are tons of barriers out there. First and foremost, a lot of people we're working with, when you're looking at IT and you're looking at cancer, particularly from the IT side of things, people don't necessarily understand the patient flows. The next three really come together because we are competing with the priorities of other IT big programs. So the cancer agenda, the IT agenda, doesn't all come together. And the core data set is absolutely key to the future of interoperability to get systems talking to other. Benefits, no-brainer. I think it's obvious to people what the benefits of interoperability are. Thank you.
Brilliant. Thank you very much. Okay, we're going to go swiftly on. Claire's going to speak now. She was worried. She was going to, is it going to be me? Is it not going to be me? It is going to be Claire. Claire, off you go.
Are you sure?
Yes, I'm definitely sure.
I'm not sure. I'm
Do you want me to do your slides? Oh, is it going to be... Would you like to go, David? Go on then, you go, David. There we are.
Does that help?
Perfect, thank you.
Thank you.
Is that right?
Yeah.
Yeah, go on then.
Yeah. Okay, thank you. Okay, I've got the joy of having the opportunity to repeat a lot of what Joe said earlier on, because he's the Chief Executive of Merseycare and I'm the Medical Director. And but I won't repeat everything. It will be an opportunity to think in a bit of depth over 7 minutes. So we talked about perfect care. Clinicians are measuring quality. We've defined quality. That was the start of our journey. I'll talk about the partnership with the Risk Authority in Stanford, and also as a digital exemplar, what that means both to me as the medical director and CCIO, but also the colleagues, some of whom are sitting in the audience and are responsible for all this good work. So it's great to talk about perfect care. I believe healthcare can be much safer. We talk about the aviation industry, nuclear power industry, lots of industries where things go wrong. Healthcare is woeful. And perfect care came out of reports in the States about 15 years ago. Yeah. And I think there's an opportunity using technology to make things safer, such as electronic prescribing. So that's how an organisation, our board, has been trying to visualise why getting care right is possible. And also the culture in which you do it is a culture that shouldn't be scared of failing, it shouldn't have blame, it's a just culture. So the cultural underpinning, I think, has been part of why, as an exemplar, we think we can learn quickly. So relationship with the Risk Authority Stanford, Silicon Valley, about 3 years ago, we got to talk to them about a project. It's called Partnerships for Patient Protection, with about 7 organisations in the UK, looking at incident reports, automating them, using machine learning, giving you information, and then using design thinking to make things better. We've got evidence that that's starting to work. It also got us into conversation with Stanford about applying their technology in other ways. So they introduced me as a novice to decision science. They used to do all this by hand. They had a whole room full of analysts, and then he decided to turn it into a computer algorithm. So they've automated decision making, and they can add value to their organisation because they've got information and data that can help guide decision making. Really, really advanced approaches, which I'm just so envious about. But they're working with us to help us get there, really. So just some of the things. So when you're in a committee or board, you want to know how many staff to have. You can start to plan with much greater precision why you want people, where you want them, what difference will it make, and what value will it add. So some, I think, pretty sort of exciting stuff. So they've got the technology, and they were inspired by stories that we'd had about people who'd taken their own life, died by suicide, and our ambition to try to see suicide as something that can be eliminated. We've had a lot of interesting feedback about that sort of ambition, but it's led over the last 18 months to an application that's been developed. We've got ethical approval, and we're looking at how recruiting people in our inpatient services in the next couple of months, in parallel with the Stanford Hospitals network over in California, and they're going to do the same thing. And the idea is that there isn't really a good way of predicting and risk assessing suicide and self-harm, so we're going to use big data. We're going to collect data from apps, we're going to use machine learning and develop risk algorithms and keep building on this. So it's a way of, I think, giving people an opportunity to help monitor their care, to engage with technology and to engage with a research programme. What's been very difficult is getting this going, because I've tried to talk to people about how many times have you developed an app, got a research study around it, got funding, etc., and there aren't many people who've done it. Lots of people are developing applications. Very few people have got an evidence base behind whether it works or not. And actually, one of the hardest jobs we had, and I spent 2 hours on the phone to a data protection lawyer, was trying to work out how on earth do you share data? Where is the data? Where does it go? How do you get it back? How do you de-identify? How do you stop it being re-identified? All the sorts of hurdles and loops that I think ultimately we'll get better and better at and start to evaluate technology very quickly. Because ultimately, research around these sorts of things can be very fast. You can do your analysis almost immediately. It's actually getting through the hoops, so you've got very safe processes. And these have been designed by people who've had suicidal thinking. This is definitely co-produced. The other thing the Stanford people taught us, I suppose, is design thinking, and I found it's a really good way of engaging clinicians, because it's made them think, actually, if put yourself in the position of somebody using a service, how can you get prototypes? How can you test that out? And we've been trying that in different ways in the organisation to reduce restrictive practices, to reduce self-harm. And I think it's really been sort of taken on board by clinicians. So I think it links to technology because you're measuring change. You're giving people tools to measure change. So it's a bit about what we put forward as an exemplar, and we've worked with 6 other mental health exemplars, sharing ideas. What's coming out to me is, I think, an exciting time, certainly in my career, around predictive analytics. You know, I started off reading paper records, then I started reading electronic records, now the records are reading themselves. And I think that gives you augmented clinical judgment and decision making, and it's really exciting. I did it today with a sat nav. I did it today with my predictive text. In my own life, I'm using predictive analytics, I'm using machine learning, but actually when I go to work, it's a different world. So we're catching up, but I think that's going to be really exciting. Something else we're doing is looking at trying to anticipate when people might go into a crisis. And this is some work we've worked with Otsuka Health Solutions. That curve should be closer to the top left-hand corner if it's really good. And what we're finding is that we are identifying people as they're going into a crisis in mental health, and now we can really look into that and find out what worked. What was the outcome? Did people go into hospital? Did they stay out of hospital? So I suppose given us insights into our practice that we've just never had. We've sort of had a view, but actually this gets you down to a level of precision that we've never seen before. And that's a bit about the background and trying to understand how good are we predicting crisis and what do we do about it. And most of the time we're getting it right, but some of the time we think people aren't going to into a crisis, and they do. So we're going to now be able to look into that and find out what happened. It's a bit more about the dashboards. And I suppose turning this into visually interesting information is powerful for clinicians and service users. And this is what we're trying to do, dashboards, and trying to make this attractive so people engage with the technology and helps them make better decisions. So to summarise, I think getting the quality definition was absolutely critical to the journey. And you have to be curious, and you have to build confidence, and you have to work with people. It's great. And I think with decision science and design thinking and just culture, we feel that we've got into something here that's going to keep improving and keep helping people with mental health conditions improve. So within my allotted 8 minutes, I will draw this to my conclusion. Thank you.
Good. Thank you very much. Right, hopefully I've got this right this time. This could be disastrous if I've got it wrong. It is Claire now.
It is, yeah.
Yes, good. Excellent.
Lovely, thank you. And congratulations for trying not to pronounce my surname. If anyone thinks they can do it, try later, but I can guarantee you can't pronounce my surname. So I'm from Evergreen Life, and some people in the room will have heard of us, and many of you won't have heard of us because we're relatively new in what we're trying to achieve. So I'll just give you a quick idea of who we are. We're a small team based in Manchester, and we're focusing all of our efforts entirely on people. And it's a real change for us. We all come from an NHS background, working either for the NHS or with the NHS, and working with clinicians and patients. So for us to move what we're doing and to become truly people-focused and to try to stop saying the word patient is incredibly difficult. And as much as we always thought we were people and patient-focused, we found out that we aren't when we really try to do it properly. So what we've done is we've looked at what people want from their health, and we've tried to create a company based purely around that. And our slogan is people-powered health. And it's about giving people the health that they want, rather than the health that we want to give them. So what we've done with the NHS, because although I say we're another company, we're no longer working directly within the NHS, we are the NHS still because we're NHS accredited. Everything we do through NHS Digital. We do everything that we release is witness tested by NHS Digital, so we're completely there. And if you go to NHS Choices now for your GP practice, whichever GP practice you happen to be, and you click on online services, it will show you the Evergreen Life service. It's an online patient-facing services solution. So we offer it on a website and through an app. And you may be thinking that you've seen it before because we've had online patient-facing services for a while. But what we do is we do the first ever cross-platform solution. So when you look at a patient and they want to access something online, some kind of service, the first thing they had to do previously is know who their GP software provider was. And while everyone in this room will know who their GP software provider is, the man on the street really doesn't know the answer to that question. They know they have a GP, they're not aware that there are different GP software providers in the country, never mind which one is theirs. So we've provided a service which covers all of the GP software providers. And for people in this room, they will know how very hard that is to have a full working integration with EMIS, with TPP, and I'm not sure if I'm allowed to say this, but I will anyway, a week on Thursday with INPS. So we'll be live across the whole country. And that's taken a huge amount of effort on our part, and it means that the patient really can access, and that barrier has disappeared. So at the moment, we've got over 200,000 users. We haven't told anyone this exists yet. This is one of the first times we've spoken on this kind of stage. And we will be telling the world about it soon, but without telling anybody, we've got over 200,000 users. I think we've just gone over 250,000 this week. So we have 3,500 people across the country every week finding our solution and using it. And I think we've had over 3 million NHS transactions completed through it. So that's someone booking an appointment, viewing their record, ordering a repeat prescription, messaging their GP, all of these different patient-facing services actions. Just mentioned we're cross-platform. The other thing that we can do, which is quite different to other people out there trying to do patient-facing services, is that we look at what else the patient or the person wants to do. So people do want to consume their data, they want to own it and they want to have access to it, but then they want to do something else as well. So we offer people the opportunity to do things like set their medication reminders. So if that person wants to say, I want to take this at this time and at that time, they can do that. But what comes off the back of that is a medication adherence record, which they can then share with their clinicians. So we're giving the person what they want, and it's helping the NHS, even though that wasn't our primary aim. Our primary aim is always to help the person. Another thing we've let the people do is a feature we call Share and Care, which allows the person to share their record with anybody they want to because it's theirs. So we found that the caring community in particular has been really interested in this function. So you've got a lot of really great trusts across the UK. We're now talking about the triangle of care, about the idea that you've got your carer, your patient in this circumstance, and your clinical team, but you need that third element of the triangle. So what that person can do is share their record. Personally, I've shared it, my grandparent has shared hers with me and with my mother. And we can see, because my grandma's still independently living, we can see when she takes her medication. We can see at 10 o'clock she was supposed to take the red pill and she took the red pill. And for us, that's invaluable, and for her, that's invaluable, because it means that she keeps her independence, and we get what we need as carers as well. But it's not just carers you can share with anyone. You could share with your consultant, you could share with a private consultant, because when we've talked about sharing, and a lot of people have talked about sharing data today, and we've talked about all of the IG issues around sharing data, I'm allowed to share my data with whoever I want because it's mine. And it's been wonderful today because so many people have mentioned the patient and all the different things that we should be doing for patients. So this is where we are at the moment. We've got a personal health record and we've got patient-facing services in a rather beautiful app, if I do say so myself, and on the website. But we want to take it further than that because that's all very much about sickness and it's about ill health. And we want to bring people into being engaged with their health and their well-being before they get sick. One of the ways that we're doing that is that we're now looking at the concept of goals, the concept of what does somebody, when we say let's give someone the health they want, well, what is the health they want? What is the health care they need? Let's go let people say what they want to achieve, and then let's work out how to get them to that place. From a GP perspective, we're also offering some services for GPs to actively, I keep looking this way to see if the light changes there, by the way, when I have to stop. That's why I keep doing this. We're looking at ways that GPs can message their cohort of patients. So at the moment, there's lots of different ways that GPs can contact their patients, but sometimes they're quite broad messaging, which you can get out there. With our solution, you can message just the people you want to. So say you want to message everybody who needs a well-man check, you can say it'll be everybody within this age group. Or say it's something about your flu jabs, you can say I want everybody within this age group who has asthma. So that way we're making sure that when that person receives communication from their GP, it's a valid, personalised communication for them. So they're not getting the overload of information from the NHS, they're getting what they really need and what they want to see. The other things we're working on at the moment is we recently released a DNA service, which may sound a little bit strange from a patient access perspective, but what we want to do is give people access to all of their information in one place where they can see a full image of their health and well-being. So if they decided to take a DNA test to find out things about their health and well-being, that would then be part of their personal health record, which they could share with any of their clinicians. And that is just the start of what we're doing. I just wanted to give everybody a chance to find out who we are and what we're doing. But if anybody wants to discuss it any further and find out where we've got up to and exactly what we're planning to do next, please come and have a chat with me later.
Good. Excellent. Rebecca, yeah? Rebecca's going to go now.
Is there any way to turn the lights up in the auditorium?
All right, is there anybody around that oh, look at that. You say,
I don't like it when I can't see you.
You like to look at the
You
whites
can all
of their
just fall
eyes.
asleep.
Yeah.
So, I feel like I should do some lunges first before I start, 8 minutes. Whew. Right then, sorry. That's me. So I'm here to present about the Code for Health movement, and this movement is already alive and kicking in the NHS. It's supporting 39 clinical communities that have been formed by clinicians like me that want to learn, that want to change and want to make things happen. They want to improve the quality of the patient care. So a bit of background, I'm a dentist, I'm a frontline dentist. I spend 2.5 days a week providing clinical care. I also am a researcher, I'm a clinical academic, working with participatory methods, so working with service users and clinicians and managers to try to make services better. So, the Code for Health communities, we have some really key design principles. And the first three, I think it'll be easy for you to see as a frontline clinician, it kind of makes sense. I understand that health and care services and digital tools that support them really need to be co-produced. Service users, service providers, working with tech people. And the Code for Health communities are all led and controlled by clinicians who are part of them. This is a true grassroots movement. Now, today, as I listen, there's been lots and lots of talk about learning and sharing learning. And I think this is really, really important for me because I have this real core belief that as a clinician, once we've solved a problem, we tell people about it. That's a thing that we do as clinicians. We help each other, provide good care, but it's also something that I hold really dear as a clinical academic. Once you've solved a problem, you publish it so people don't have to solve that same problem again. So for clinicians working with Code for Health communities, open standards are non-negotiable. And actually, open source is also ideal. And the reason why that is because open standards and open source actually gives us a fighting chance of interoperability. So this diagram describes what the Code for Health initiative, or Code for Health movement maybe, does to support clinicians like me. So 2 years ago, I was up top left corner. I was frustrated. I had this real I knew what my problem was, I knew what the clinical need was, but I was lost in the system. I didn't really know who to go to for help. And the Code for Health communities scooped me up and they allowed me to go through this journey of learning, not sitting in a lecture theatre or being talked to, but actually doing a project, making things, developing things, working through prototypes. They provided resources for me to do that. And now I'm in the bottom right-hand corner, I'm ready to go into production. And I actually think 2 years is too long. I actually think with better resources, most clinicians can do that within 6 months. And the learning that goes around that is really, really useful. So, the next 2 slides are going to be some video clips. The first one's from the Open Odonto clinical community in the Code for Health initiative, and that's the community that I lead. as an NHS dentist, and it's focused on very much on those kind of building blocks, those mundane building blocks, the not so sexy tools that we all need to be able to deliver good patient care. It's the minimum service that patients should get. The second video clip is from Naveen, who's a consultant radiologist, and he leads another Code for Health community working at the real cutting edge with technical sophistication. So it'll just give you those kind of two different perspectives. Behind me, there's going to be another 20 slides that'll just keep on moving. But for the next couple of minutes, I'm just going to tell you a little bit. There's 3 things that I think the Code for Health community has done for me. And the first is that it's really provided me with learning. As I said before, not stuffy, will tell you what you need, but actually listening to me and then putting me in contact with people. The second thing that it's enabled me to do is it's enabled me to kind of make change happen, to really become resilient. If someone says no, you don't take no for an answer. You go and try to find a different way of doing things. And then the other thing really is to find that network of other people that are like you, that you can kind of phone up if you're trying to work a problem out. So my offer to you is it's here, it's ready, it's open to all of you. Come and get behind it.
Good. Yep. And last but not least, Anne.
I really like speaking to other people's slides.
Oh, you're going to have to go through them all. Sorry, I should have talked. Do you want me to click? Oh, there you go.
Technology.
Sorry.
I'm clicking.
Are we moving? Nearly. Yeah, there's loads of guys listening up top.
There we are.
There we are.
Thank you. Thank you very much. It's not really known for me to speak for only 7 minutes, but I'll do my best. And as I'm presenting other people's work as well, I'm very mindful of the fact that I want to do them justice. You heard earlier on, by the way, I'm Anne Cooper, I'm the Chief Nurse at NHS Digital. But I've been working in collaboration with the Royal College of Nursing and HEE on some work around what we call digital capabilities, and that's what I would like to talk to you about today. And Jane alluded to something called Every Nurse and E-Nurse this morning, and that's part of what I'm going to talk to you about. It's sort of a digital manifesto for nursing, but I'll tell you a little bit about where it came from. So around 3 years ago, I pulled together with the RCN a group of people who were on the screen who had an interest in understanding what we needed to do to try to make the agenda that we've all been talking about today more about what frontline staff thought was the right agenda, rather than taking informatics away from being a specialty and mainstreaming it in the frontline workforce. And Joe talked earlier on about big, hairy, audacious goals, and that's what we decided that we were going to do. And the big, hairy, audacious goal that we set was to transform every nurse into an e-nurse. It's also about nurse education. We were very mindful of the fact that we've got a pipeline of nurses coming through, that we have different groups in the nursing workforce. So there's older nurses, it feels really strange that, older nurses like me, but also we've got younger nurses coming through who also already have quite a lot of digital capability. So this was the manifesto. Some of the things that we heard, again, Joe talk about this morning, and Keith really, is about how do we stop electronic systems and digital stuff. How do we stop it being about just recording what we do? Nursing has sometimes a track record of being quite tasky, but technology and data can stop us being a doing profession into more of a knowing profession by lifting some of the data and understanding and building that into the way we practice. And we decided that capabilities was more important than competencies. Competencies is a word that we overuse, I think, in the way that we operate. Competencies describe how we work now. Capabilities describe how we need to work in the future. And we wanted a framework that would promote nursing is knowing. And this is what happened. We found that the RCN, in that work that we'd started, was also working in parallel with some similar work in health education England on digital capabilities. And the two pieces of work came together, and we have just done a soft launch of a new digital capability framework, which you can see on the screen there. We are starting to elaborate the descriptions that sit underneath there for a number of different professional groups. And I know Mohammed is in the audience, and we're starting to work with nurses first, because they're one of the largest groups in the workforce, and then we're going to move on to pharmacy and see where we get to. It's interesting, the capability framework is not original. It came from higher education, and actually it's aimed at looking at capabilities for digital citizens. Its origins sit with lecturers and people who work in higher education. A little bit more information about it there. And this is what we think we're going to use it for. I can't see my screen. We need practitioners to be able to, through things like revalidation, have some benchmarks to be able to articulate their needs. We need to be able to embed this in undergraduate education. We need to be able to inform local and national policies around the workforce and how we skill up. So we are tying the two pieces of work together. So the RCN are going to be leading on the campaign around every nurse and e-nurse. We will be working with HEE to start to develop things like a self-assessment framework. It's one thing to have a series of pieces of statements around what we would expect from people. It's another for them to be able to navigate that and to understand where they might need to focus their learning and development opportunities. And that's the video that we've produced, which I can't show you today because we've had to make some changes. One of the things that's been really interesting about this particular project is how a number of things have been brought together. So the RCN discovered that HEE were working on a similar piece of work, and equally we've used some of the storytelling from the Intra-Open storyline. That's Michael's story that we've used for every nurse and e-nurse. So this is all about future capability, it's all about frontline staff, it's all about learning and developing and pushing informatics skills out into the broad workforce. Thank you. Under time, Professor. Under time, Professor.
You know, that's the first. I work with her, and that's the first time she's ever been under time.
Thank you.
Thank you very much. So I'd like to invite Keith back on the stage so we can actually start to give some closing comments. So I want to thank my presenters, my speakers. You can stay there, please do. Great, thank you. And we're going to build on this as we go forward. I think this is a format we want to get through, we want to drive, we want more. So next time, I've clocked a lot of faces here. I want some of these faces up on the stage, please, next time for the Pearls of Wisdom. You know, if you're taking problems and you're solving them, we need to communicate them. You've got 8 minutes to communicate them, but we need to drive this learning culture. We've had some challenges thrown out. It's good, but next time it's you. So, Keith, do you want to go first in summing up?
Sure. Well, great day. I mean, what a great series of conversations and lots of consistency about what's gone through there. A couple of things that struck me in conversations. I mean, we always like to beat ourselves up because we haven't done enough, but which is a good thing in some ways because it pushes us on. But remember that it takes 13 years for a medical breakthrough announced in the New England Journal of Medicine to be popularly used right across the health system. 13 years. So, you know, we're at the start of a journey which we're starting to pull together really, really well. We've got the most advanced primary care system in terms of digital capability in the world. You know, better than anywhere on the planet. We've got a cancer database, if none of you know about it, which is the envy of every single system in the world. It's got longitudinal records and full complete data sets of every patient with cancer in the UK. And it pulls that together seamlessly for 300,000 tumours, as we heard, 300,000 tumours a year. So a phenomenally rich source. We've got an infrastructure across the NHS, across the country, which again is the envy of the world. The NHS Spine, the HSCN network, which is rolling out, NHS Mail, etc. All of those things which are developing, getting bigger and bigger, and are available. And I was talking to someone in the break, and they were saying about messaging. I said, well, we've got NHS Mail, which is a secure messaging service. We've got Skype for Business, which is a secure messaging service. And you've got apps associated with that. A lot of stuff that we've got that we're not using functionally now, we're not using to the maximal amount, that we will do so over the coming months. It comes back, though, to what we're trying to do here, which is improve patient outcomes. And we can only do that by engaging people on the ground who actually deliver clinical care. It's not about the technology, it's about the people who deliver clinical care, it's about engaging patients. We've heard that a lot of consistency about how we need to get patients engaged in this agenda, and certainly the digital agenda. And it doesn't matter what age, it doesn't matter about the age. We've done numerous surveys to say that people who are in their 90s are just as tech savvy and tech avid as people in their 20s. So right across the system we can engage patients in this, and we've got to get the clinicians on the ground bought into this, because as we do it and the hard yards are done up front, the valley of despair, we know that when we implement EPRs that there's a tough road to go, but once they're in there and they're running, you really start to reap the benefits. You guys are the leaders in this. This won't happen because I'm the CCIO sitting up there in Ivory Tower at Skipton House making decisions. This will happen because you get out there, you spread the gospel, you enthuse and engage your workforce and drive this from the ground up. That's the message that comes from platform organisations. The government's bought into this. They put £4.2 billion into the start of this journey. We've got a Secretary of State, love him or hate him, he likes tech, and he's really tech savvy, and he's a real advocate for what we're trying to do in this space. So we're very fortunate in that ground, and from Treasury right down, Cabinet right down, we've got a momentum building. So let's go from here and just build on this. Go back to your organisations, get people enthused in this. Yeah, it is hard. Yes, it's frustrating, but let's not let that stop us. Let's give it added impetus to try and save it. And I think, as you said, don't take no for an answer. Find a different way of doing it, you know. Until someone says no, 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 get out, slams the door in your face, remember they're really in the process of saying yes, they just don't know it yet. So go forth and digitise. Thanks.